So this topic, I think that is quite nice start, Professor Tran, when we discussed about planning the program. We thought that how could we, kick off this meeting. So I think that this would be quite a nice topic to begin with. And when I actually prepare it, I look at the time. I've got 15 minutes for this topic. So it's really a challenge to talk about the challenge in Indo-China in 15 minutes. So it's not easy at all. So you already give me the challenge to start with. So, but here we are. I think that instead of, I'm going to bore you with a lot of statistics about various number about the Indo-China, I think that it would be nice to think about these challenges from the patient perspective. So I think that would be the way to do for it. This is my disclosure. And before I begin to that, I like these quotes actually. I try to repeat it without looking at it for a few times. It's not easy at all. I think that many of you might heard about this quote from Donald Rumsfeld. I think it's 20 years back. So we know there are known knowns. There are things we know. We also know there are known unknowns. That is to say, we know there are some things that we don't know, but there are also unknown unknowns. The one that we don't know, we don't know. I think that many of you might heard about that. If you shut off the screen and ask me to repeat that, probably I would not be able to. But I think this also reflects to what's happening in our Indo-China. In movement disorder, there are many things that we know. And there are many things that we know that we don't know. And there are many others that we don't even know that we don't know. But I think this is one point that they missed here, that they didn't talk about, we don't know that we know. Okay. How to deliver treatment in movement disorder in China, it includes a lot of factors, but I try to simplify it. So I think that what is important here, if you look at the patient center, that is what we all know. It's constitute a basic factor that include the healthcare professionals, we as a neurologist, for example, carers. Most of the Parkinson disease patients, movement disorder patients have a carer, and also the treatment and medication availability. I think this is the three important basic factors that constitute how we deliver basic treatment to the patient. And in order to illustrate this, I'm going to take you like 1.5 minutes to watch the video of a typical Parkinson disease patient in Thailand. I'm sure it's quite similar elsewhere, but I think it would be nice to reflect this visually to all of us. You can read the English subtitle.
อายุ53 ปีข้างเป็นข้างซ้ายก่อนมันจะเอื้อมไม่ได้จับพวงอะไรหมุนพวงอะไรต้องใช้มือขวาช่วยมือซ้ายจับช่วงแรกยังไม่มีผลเท่าไหร่เพราะยังสามารถมีแรงคือวันนี้การเดิน3 ก้าวไม่ค่อยออกตอนที่เริ่มเป็นใหม่ๆผมสังเกตได้ว่ามือผมไม่เป็นช้าลงทุกวันผมก็เลยไปหาหมอ
เริ่มจากแขนค่ะแขนข้างซ้ายเริ่มหนีบลำตัวจากหนีบลำตัวก็มีการทักกันว่าแขนเป็นอะไรในการเดินของเขาจะแกว่งข้างหนึ่งข้างขวาข้างซ้ายจะหนีบไว้เขาก็จะตอบว่าไม่เป็นอะไรเป็นมาระยะหนึ่งจนถึงขั้นเขาบอกว่าเขาจับของไม่ถนัดเราก็เริ่มหาหมอโรงพยาบาลต่างๆทานยามาประมาณ 4-5 ปีก็เกิดอาการดรอปหรือการไม่เดินเลยคือช่วงนั้นเริ่มตันนะคะเริ่มแบบเขาซุดจนเป็นหินเราก็เลยดูทีวีแล้วเจออาจารย์ก็เลยบอกเขาว่าไปกันเลยมันไม่มีอะไรมากไปกว่านี้แหละส่วนเขาก็เห็นเขานั่งร้องไห้แล้วตั้งแต่วันนั้นก็ได้รักษาที่จุฬามาตลอดและอาการเขาก็ดีขึ้น
Okay, this is a short clip to illustrate that typical Parkinson's patients that we encounter within our region, they have a lot of disability. And I think if we look from the patient perspective, I'm sure that we encounter those that we see in the left column, which, could be symptoms that are multiple, freezing of gait, for example, like this patient, the fluctuations of the symptoms, the progressive nature that have a psychosocial impact to the patient and the family themselves, and also the stress to the carer as well, and also, what's happening financially, I think that we are aware of. And this is called the disease burden that individual families that encounter. I put it a little in the small box here on the right, reflect the resources that we have in our region. We know that we have some treatment for that, but there are variable in not just talking about the countries within China, even the cities within Indo-China, within the country, there are different availability, I'm sure. Accessibility is also the issue. Community support, family support, but not to forget that, within Indo-China here, when encounter some environmental risks on Parkinson's disease or other movement disorders itself. But even though we are just, in this small area of the map, nowadays we are part of the global community. So we want to feel how us as an Indo-China can be reflected globally. And I think that this map or this figure illustrates very well. If we look at it in terms of the growth of the Parkinson's disease, you can see that the area in red are more concentrated within Asia. China, India, Indonesia expect a large increase of Parkinson's disease patients. But it doesn't mean that Indo-China here, patients are not going to, we're not going to have more patients. Part of it might be because we don't have the data at the moment, and there are many things that we can work around that to have this data becomes available. But I think that you can see that you can expect the burden that's going to be concentrated in Asia and the region. I show you this statistic. I'm sure that if you search in the Google, you will find a lot of this. And burden of disease, I showed you earlier, reflect by the patient, how they encounter in the video. But in terms of the research perspective, there are different ways to do it because we want to make it quantifiable. And I think that if you look at the disability adjusted life year, the only figure that I'm going to bore you in this 15 minutes, you can see that the number for the Thailand, for example, or the Vietnam, as a two representative of the in Indo-China, you can see the Cambodia there and Malaysia. If you put that together, disability adjusted life year is going to be above 100,000, and that is quite, astounding. And the mortality in our region for the movement disorder patients is quite significant themselves, and you can see it's on these two maps. So, okay. So I'm sure you can appreciate the burden of the disease that the patients encounter in different sorts of ways. Patients themselves, the video, the numbers and so forth, mortalities and so on. But look at the resource, what we have available for movement disorder patients within our region. This is from the publication that we did together, Professor Tran, 2 years already. And we put in, try to find the statistics of in terms of the number of patients and the number of the neurologists in the bottom. You can see that we have less than 2,000 neurologists within Indo-China. but we have above 100,000 patients in Indo-China, which again is likely to be underestimated number of patients there. So you can see that our resources in terms of the tackling the movement disorder patients within our region is very significant. And probably you don't need this figure to make for us to realize that our manpower is pretty stretched in terms of the taking care of these movement disorder patients. And I think that this, we hope that the number of this figure will change and the increase with the further collaboration and so on. And comes down to the last part, which is the treatment availability. When I look at this table, I thought that this table, reflects the number of doctors and so forth, but they talk about the advanced therapy. Particularly, we discussed before about the availability of deep brain stimulation within Indo-China. I know that, you are one of the pioneer. There are several centers within Vietnam can do the deep brain stimulation. Malaysia can do, Thailand can do, and so forth. But I'm sure that the accessibility for the patients to come to have this kind of treatment is not easy. And I'm sure that it's quite a long waiting list there. So there is the scattered of the super niche center that can provide the treatment within Indo-China, but it's not freely available. But if we look down further a bit more in terms of the medication, oral medication, for the countries in Indo-China, you can see some, difference in availability there. We missed the data from Cambodia, but I think that today we will know the data from Cambodia since we have Dr. Nawut here. And levodopa, of course, is listed, but again, I believe that it's also not freely available within countries within China. So, we talk about the manpower, we talk about the treatment. I think the last part that we need to discuss briefly is the knowledge of the movement disorder itself. And I think that's why we have the conference like this today. And that brings me to the work that we did quite a while back, 8 years ago now. We actually did the survey on the knowledge of the Parkinson disease among medical professions. And you can see that this 26 item, there are some gaps in knowledge that you can see. Not only in terms of the diagnosis, I think the challenge part that you can see here is the medication about the knowledge of the medication adjustment, the medication treatment, and so on. And I think that this conference will serve as a platform for us to share the knowledge and improve the knowledge on how we treat Parkinson's and movement disorder patients. But when I did this, I got the question asked that, are you sure that this type of activity that we do together going to improve the knowledge of the doctors who come here? And thanks to our colleagues in Laos, I think that we did this. Apason, you remember that we did this teaching course together in Vientiane, and with the support from the Movement Disorder Society. And this is the results is pretty clear that following even the one-day lecture, the knowledge among the participants has improved. So, this is just to say that what we do has an impact. And the impact has to be continuous. And the issues of the disparity of the movement disorder conditions is clearly recognized by the World Health Organization. I attend this kick-off of the World Health Organization launch on the global disparity on Parkinson's disease. And that is followed by this publication that addresses 6 important steps to address this disparity. You look at it, you can read it through, but you will realize that each of the steps is not going to happen overnight. It requires, a lot of effort, groups and so forth. Like, for example, lack of epidemiological data. We're not going to have this, within a stance. So it needs a lot of collaboration to put the effort together to have this data available. And I think that is very much in need in our region to have this kind of data so we can actually implement many other interventions. Look at the patient perspective, lack of carer support. To have this platform available to the carer, I think that it also requires a lot of work, requires a lot of team, requires a lot of knowledge to put that together. So how can we do this? I think that we probably are already doing. And I like to use the phrase that 2 heads are better than 1. So it reflects the intuition that people working in groups are more likely to come to the correct decision than if we work alone. And I think this is what we are doing right now. We work as a group. This is not 2 heads, this is 100 heads. So 100 heads that we have today are going to be much better than 1. And we already put 2 heads together, Professor Tran, for this Indo-China Movement Disorder Conference. So what I'm going to end my topic on the challenge in the 15 minutes here, I would like to end it by that, the situation nowadays are even more a challenge in the age of disruption. Disruption that we face nowadays is actually a new normal and fundamentally redefine the way that we work, live, see, and manage our patients. So in order to thrive in a digitally disrupted world nowadays, we need to collaborate. I think this is very important. Collaborate amongst our neighbors so we can embrace each other to our full potential. But to implement whatever WHO has outlined there, it has to be stepwise. Do whatever we can, small at a time, but we need to think big as an action. So, part of it, we're probably not going to be able to improve all the manpower at once. We're not going to be able to make the medication freely available. But I think that now one thing that we can utilize quite quickly is the digital technologies. And this is one way that we can address this challenge. And we can utilize digital technology to improve to address our challenge quite quickly. For example, the education that we do now, we do the online education, for example, we do the tele movement disorder visits. And I'm sure that there are many other applications that we can utilize across our region to collect the data and so forth. This is some of the examples. And I would like to invite the doctors here, whether on-site or online, to join this educational roadmap. I think this is very useful. It's free to join. Go into this website, you registered, and the lots of the educational materials are there, and it's free of charge. Some of us already are the ones who contribute some of the lectures here. I think Dr. Chilada did the one on sleep in movement disorder, for example. And this is the QR code that I would like to invite you all to join as a membership of the International Parkinson's Movement Disorder Society. Again, it's free for our member. So it's free to join. You just need to log in, apply, and then you can get access to a lot of information. The membership of the Oceanian section constitutes around 30% of the global membership, and I'm sure that we can have more members here. And also we have our educational roadmap within Chulalongkorn Center as well. And, I invite you to have a look at them. You can access again to this link above, and you can join a number of the lectures and activity. So I would like to really end by the world has changed and there is no going back. But we as Indo-China, as a group, evolution is a key for our region, not only to survive, but to thrive and to grow. So we need to embrace on the new knowledge, implement new technology for our benefit, and collaborate more to advance ourselves forward. So our region needs the strategy to move forward. And I just want to reflect here that, as I mentioned before, no one can do everything, but we each can do something. Each of us has different strengths and weaknesses, and I think that collaboration would be a good way to work together. We probably cannot improve our weaknesses, in a short time period, but if we work better, we can go forward very quickly. And importantly, if we give more, we can take more. And I would like to really end by that. I hope that this meeting, we will learn fast and we act strategically, as briefly discussed, for the growth of our Indo-China in movement disorder, and hope that our section will scale up rapidly. Thank you very much.
Thank you very much, Professor Ronroy Vilayasari. We have some questions for Professor. I have a question for you. What will you do to improve the knowledge in our region in the future?
Yes, I think that we are already doing this, and this is, Indo-China Movement Disorder Conference is one of the activities that, enhance our knowledge. And I'm sure if we do the pre-test, post-test here, we will get the significant results from it. But I think that knowledge can do in different ways. Looking back, when we talk about this at the opening, to have this conference to join as on-site or online, it takes months or years to organize. It takes a lot of effort, not just only manpower, but also resources and so forth. But I think it's also very important that we could think what we can do in between. And, within Indo-China, we have already done some. Professor Tran, you have already, sent people and exchange doctors and nurses. It's one way that we can do it along the way. We can do even some online activity before, in different centers within Indo-China to collaborate our knowledge, and the online activity, I think, is the way to go at the moment. So we can do the periodic intermittent knowledge activities together, and we can start small, start with one university, with the others, and then, with time, with networking, and we will grow more. When I talk to some of the colleagues in this region, some might respond to me like, oh, we Indo-China, we don't have that much of the digital technology, so we cannot do that. We're not advancing as the Western country. But I think in the opposite way, really, because if we are Indo-China, if you think that how much, manpower that we don't have, knowledge that we're lacking, you need to even try to boost digital technology to our centers in our region, because it is the way that we could scale up rapidly. So we cannot do anything that in a traditional way like before. But I'm sure that every country, every center have different strengths, and I think that if we join and we try to learn from each other on the strength, I think we will grow up very rapidly. Look at the Ho Chi Minh City. Last night I came here, very different from a couple of years ago I was here. I remember the MC mentioned that this city is a vibrant, and I fully agree, it's a vibrant city. Your medical center has grown. So I'm very impressed, by the way. Yes, thank you.
Thank you very much, Dr. Bidayasiri. Your speech gave us important and interesting data about the epidemiology, about the health situation relating to Parkinson disease and the movement disorder. I totally agree with you. They are very useful. And the next step, very important for me, is to look at the way of collaboration, of a cooperation between us, the neurologists of the region. Thank you very much.
Thank you.
Thank you. Thank you very much, Professor Roy, for your excellent presentation. Dr. Jirada Screen, please, to talk your topic.
Hello, good morning, everyone. My name is Dr. Jirada Singhan from Chulalongkorn University. Thank you for having me in this conference, and it's my honor to join this conference. I have to say that it's my first time to go outside my country after the pandemic. And after the pandemic, this is the first time of on-site meeting, so a bit excited. And at the beginning, I would like to congratulate to our first Indo-China movement disorder conference. Today, I'm going to talk the topic of basic of movement disorder phenomenology. I have no disclosure. And let me start with the 4 patient video. And which one do you think that has a movement disorder? Is patient number 1. Number 2. Also, number 3, she's described that she has a pain on her right chest thorax, and then her parent noticed that she had a tube on her body, her trunk. And the first one. Okay, let me start with the basics of the abnormal motor activity, and we subclassified into the four main category of the abnormal motor behavior or abnormal motor activity, and most of them is the movement disorder that we will learn from now on for 1.5 days. And another category is that quite important and also emergency is the motor seizure. As you can see in the patient number 1, she has the tonic-clonic jerk and also synchronous with her face that also have a jerky movement, and actually it's spreading along the motor homunculus that we call Jacksonian march. But in the first patient, it might be on top of movement disorder on her hand. And the second patient is the functional movement disorder patient. She's voluntarily to move her leg repeatedly and try to close her eye forcefully when the doctor try to open her eyes. And actually she can stop the movement when her doctor pay attention to her. And the third the patient is the movement disorder mimics, which usually refer to the group of abnormal motor activity from that cause from other cause, for example, weakness, pain, or other mechanical cause that you can see in the third patient. She actually has a mass on her right chest wall that make her trunk tilt like that. So what is the movement disorder? The term of movement disorder refers to the group of nervous system or condition that cause that either increase or decrease of movement. The movement disorder should be involuntary, but actually it can be voluntary in functional movement disorder group, or maybe semi-voluntary in tics disorder. And each movement disorder is called phenomenology. In the order to spot the phenomenology, you need to know the salience or the prominent feature of the movement and how to elicit the feature. And the clinical approach of the movement disorder is a little bit different from the general neurology. In general neurology, we usually start with the problem list when you can locate the anatomical localization or where is the lesion. But in movement disorder, the problem list we will define as the phenomenology. And it's very important to define the phenomenology of movement disorder to get yourself into the nature of the patient and the movement. And then when you know the phenomenology, and then you will have the knowledge of each phenomenology, and then you can further approach to the problem of the patient. And then the next step is what is the reason, which is the clue to determine the cause of the phenomenology, that you can identify what is the reason. The clinical cause of the problem is, like, for example, acute onset. You will think about the vascular in origin. Subacute might be inflammation, like either infection or non-infection. And the chronic might be things about the neurodegenerative. And in addition to, apart from the phenomenology and etiology, the movement disorder usually has a syndrome that you have to know. So these are the information that you should get to know to approach one patient with abnormal movement disorder. First, as I will talk in 30 minutes, is the phenomenology categorization and what to determine of each phenomenology. In general, we determine the form of the movement disorder, velocity, spontaneity, or when it occurs, distribution of the movement, the temporal association, and one patient can have more than one movement disorder. So maybe you identify the major or the prominent feature of the abnormal movement. Then go to the general history taking. And additional, you should get the family history to identify the mode of inheritance, and perinatal history, also drug or substance exposure, and then the clinical cause, as I told you before, and then keep all the information to be the syndrome or not. Okay. We subdivide, as I told you, that we have an increase or decrease of movement. So we call the increase of movement or excessive of movement is hyperkinetic movement disorder or hyperkinetic disorder. And for the decrease or reduce of movement is hypokinetic disorder. And in the hypokinetic group, there's some can be referred to akinesia, hypokinesia, or bradykinesia. Sometimes it use overlap. And some literature try to propose the definition of each term, which akinesia is the loss of movement, the hypokinesia is the decrease of amplitude of movement, and the bradykinesia is the slowness of movement. But in clinical practice, some clinicians refer this group as a Parkinsonism that you will learn in the next topic in depth. And also this is the example of the hyperkinetic movement disorder. So let me start a little bit with Parkinsonism. And the Parkinsonism is the syndrome. It's not like a group of phenomenology. It's not the disease and it's not equal to Parkinson disease. And as you can see in this picture of Parkinsonism, is combined of the bradykinesia is the main symptom of Parkinsonism, and rigidity, rest tremor, postural instability, freezing, and also fake posture. Having 2 out of 6 is the define of Parkinsonism, and 1 should be bradykinesia. So bradykinesia is the slowness of initiation with progressive reduction in speed and velocity. So we call it decrement of movement or decrement of amplitude and the velocity of movement. You can test it by the repetitive movement, for example, the finger tapping or alternate hand movement or foot tapping that I have a little bit video to show you. And note that the toe tapping is more sensitive than the heel tapping. And also you can evaluate the bradykinesia in many ways, such as handwriting, spiral drawing, voice, and also facial analysis, which also the clinical presentation of the bradykinesia. And this video showed the Parkinson disease patient with a decrement of the amplitude and velocity when she performed the finger tapping test. Let's move to the rigidity. And rigidity is the increase of the resistance to the slow passive movement and velocity independent. So this making the difference between rigidity and spasticity, because spasticity is the velocity dependent. So rigidity needs a much more slower passive movement to test it, which is different from the spasticity. And when you feel the tone of the rigidity is the constant of the increased tone, which is different from spasticity. And sometimes patients might have a tremor imposed on top the rigidity, and you will feel the cogwheeling, like a rhythmic increase of tone. So it's called cogwheel rigidity. But only tremor without true rigidity, when you test the movement, you can find the rhythmic of the tremor. So it might be not the true rigidity, but it's only the tremor. It's called cogwheeling. As I mentioned, this is not the true rigidity. For the next one is the rest tremor. The rest tremor in Parkinsonian is one of the key is to fully support the body part that you want to test in. This is one of the example. We press the patient hand on their laps, and the classic is around 4 to 6 hertz. And predominant address, and also AB and AD deduction. We also test the other component of tremor, like this is the postural tremor. And this is also another position that you can test the rest tremor to make it fully relaxed. And you have to observe maybe at least up to 30 seconds if you cannot see the tremor, because sometimes it's waxing and waning. And if you cannot see at the immediate or spontaneous, you can perform the cognitive tasks, for example, serial subtraction, backward count, and the tremor can be illicit. And if your chair has an armchair, you can press the arm of patient on the armchair. And this also the classic stool posture of the patient. He also have a rounding shoulder, arm and elbow flexion, my hip flexion, and also knee flexion. And the last one is the postural instability and gait disturbance. Which is the loss of confidence on their feet and feeling imbalance like rectal portion or proportion. And you can test by asking the patient to stand out of the chair without support. And other test is the pull test. And for the gait, characteristics are usually slow speed, narrow base, short step, on block turning, and sometimes with phrasing of gait that we will have another session of gait examination and disorder. And the phrasing phenomenon is the transient phenomena of the abrupt of the gait, like this. This video shows the phrasing of gait when he initiate to start walking. The second, when he turning, he have a short pause and cannot have. And the last one is also occur during walking. So after you know the Parkinsonism, you can classify it according to the etiology into the four main categories, like idiopathic Parkinson disease, which is the most common cause of Parkinsonism. The other, like secondary cause Parkinsonism, plus and also heredodegenerative. Okay, let's move to the hyperkinetic movement disorder. And for the clinical approach in general, you might recognize the hyperkinetic phenomenology. Like first, when you see the patient, immediately you should look at whether the movement is rhythmic or non-rhythmic, sustained or non-sustained, paroxysmal or continuous, or when it occurs, like awake or sleep or in both. The next step is when you have a longer observation, you can observe the movement like it occur at rest, action, or have an overflow. Is it pattern or non-pattern, or the combination of the various movements? And the third step is very longer than the second step is you can identify other supporting symptom or sign, like for example, exam speed, amplitude, eye movement, self-mutilation, something like that is the general scope for the approach. But in different patients, you can take alternate step. And this is the common hyperkinetic movement disorder, as your rhythmic movement is the classic clinical characteristic of the tremor. And in the non-rhythmic group, the sustained group is we should think about dystonia. And in the non-sustained group, we subdivide into non-suppressible and also suppressible. In non-suppressible, the most common is chorea and myoclonus, and the suppressible, the most common is tic. So let's start with the tremor, which is the common hyperkinetic movement disorder. The tremor is defined by the definition is the rhythmic sinusoidal oscillation movement of body part due to the regular contraction of the reciprocal innervated muscle, either synchronous or alternating. And also subclassification of the tremor refer to the resting and action. And also action tremor can divide into the postural and kinetic tremor. The postural tremor, which is the tremor occur when the body part is against the gravity. And the kinetic tremor is the tremor occur with the activity. So this session I gonna cover not in depth of the clinical approach because we have a separate session about how to examine the hyperkinetic movement disorder. So let's start with this first patient. I have an answer. I want to ask you what is the answer of this patient. She has the hyperkinetic rhythmic oscillation, as you can see, of bilateral hand, arm, and also when she performed the postural and also kinetic. And she also has a tremor rhythmic on her arm, her head, and actually her voice. And she has a severe tremor when she pouring the water, when writing the spiral. And you will see the axis of the tremulous light is shaking when she performed the spiral test, that she has the essential tremor. And the spiral test usually equal in the shaking characteristic. For the essential tremor, it usually bimodal at the onset in the second and the sixth decade, and usually has an action and postural and kinetic tremor around 5 to 12. Then usually bilateral and maybe involved in hand, foot, head, and also voice. And, they might have a common family history in the AD transmission. So the next one is the dystonia. Dystonia is defined by sustained or intermittent muscle contraction, causing an abnormal and often repetitive movement of posture or both. And dystonic movement are typically pattern and sometimes twisting and maybe tremulous on top of the dystonia. So this is important is the combination of the movement and abnormal posture. So if you only look for the only constant abnormal posture for dystonia, you might maybe underdiagnose of the dystonia or misdiagnosed to be other problem. And the movement usually have pattern that I talked before is usually repetitive and predictable movement when you observe patient long enough. And sometimes it might be rhythmic or tremulous on top of the dystonia. And this is the example of patient with generalized dystonia. You will see that she has a sustained and sometimes intermittent contraction of her face, her neck, and also make her head twitching. And when and you will see that her hand also has a dystonia, an abnormal posture too. So she has a generalized dystonia. When you see the patient of dystonia, you can approach into two axes according to the consensus of Movement Disorder Society. The axis one is the clinical characteristic. The axis 2 is the etiology. Actually, this axis we can apply to other movement disorder too. For the axis 1, this slide shows the clinical characteristic of dystonia. The first one, according to the age of onset, the body distribution, which dystonia can present only in one part with its focal, or as a segmental, or as in different is called multifocal, or in general like with or without leg involvement. And the hemi body is quite important because if you see the patient with hemi, the problem, something it might imply that you have to look for the contralateral structural lesion. And the third one is the temporal pattern, which is include the clinical cause of the dystonia, like a static or progressive, and variability, which is present or not, like persistent, action, specific, is is diurnal, which is some dystonia doesn't come out in the morning and come out in the evening or afternoon. As you may know that this is the character of the dopa responsive dystonia. And the other dystonia is my paroxysmal, which is mean the patient usually have a normal or different in between the episode of the dystonia. Also in the axis 1, you have to emphasize the associated feature, which is important. You may remember the old term of dystonia as a primary or idiopathic dystonia. In this new classification, we emphasize dystonia as an isolated feature with only tremor around to occur together with dystonia is isolated dystonia in the old term. Or the dystonia have a combined with other movement disorder, for example, Parkinsonism. Or not only movement disorder, it might combine with other neurological disorder, also have to consider in the axis 1. So for the axis 2, we consider the etiology. It can be divided into nervous system pathology, and also you have to consider of inherited or acquired. So the third one of the hyperkinetic movement disorder is chorea. Chorea is the irregular, flowing, non-stereotype, random, involuntary movement that process sometimes like a rating quality of movement. So the chorea might be equal to random. It's random in muscle affected, at random at time, or random of activity of duration. Okay, you will see the example of the generalized chorea. You will see the flow life an irregular movement and non-pattern. It's different from dystonia. For the dystonia, when you observe for a long time, it might be repeat of the pattern, but the classic chorea is like the flow line and not repeat of the movement. This patient has a diagnosis of Huntington disease. Yes. In the face, in finger, and the gait of chorea sometimes quite bizarre or irregular gait, and you might be misdiagnosis of the functional movement disorder in choretic gait. Okay. Let's move to the barism. What is it? The barism is the variant of the chorea on the extreme end of the chorea spectrum. It's particularly involved the proximal joints, usually in the large amplitude with the flipping movement. Most usually in hemi-body distribution, which we call hemibarism and hemichorea. Which I told before that we have to think about the contralateral structural region. In barism, we might think about the contralateral striatum or subthalamic nucleus that associated. I will show you this old lady with acute onset of the left side hemibarism. You will see that she has a quite violent on her left arm and leg, with like the chorea movement, but very high amplitude and more aggressive. At the beginning, her blood sugar was 350 milligram per deciliter, and she has the uncontrolled diabetes. And her diagnosis is the hyperglycemic chorea, which is usually present in hemi-body barism in Korea. So the next one is myoclonus. For the myoclonus is the movement characterized by brief, intermittent, and shock-like jerky movement. The classification of myoclonus might be classified according to the clinical and physiological. For the clinical presentation of myoclonus is most often unrhythmic or non-rhythmic, but less common, it can be sometimes rhythmic form. It might be in focal, segmental, multifocal, or generalized when they involve body, more than one body region. And the question that you have to ask yourself that the movement is asynchronous or synchronous, and when the all body parts are jerky simultaneously or not. And are the movement occurring spontaneous without trigger or at all, or are the reflex in many different trigger, or as a second sensory stimulus, for example, touching the limb, bright light, or loud sound that can trigger the myoclonus. Finally, the importance of the myoclonus is it can be more present when you move your body part, and you will see that the fast jerky movement can interfere the smooth movement when the patient move their body part. And in contrast to the other movement disorder, the electrophysiology is important to access the myoclonus. The origin of it can define the origin of the myoclonus from the electrophysiology, and it might be come from the contralateral motor cortex, brainstem, or sometimes segmental of the brainstem, or spinal, or multi-level of the spinal, which is the propiospinal myoclonus. And for the propiospinal myoclonus, sometimes but not always is considered as one of the functional movement disorder. And another origin might be of the myoclonus might be come from the peripheral in origin too. So this video show the patient. You can describe like an hyperkinetic, non-rhythmic jerky movement of the distal hand when they outstretch his hand, and characterized by postural lapse, which is the classical presentation of the negative myoclonus. And the second patient that touched her hand, which is the sensory stimuli that can make the myoclonus happen. And move to the fourth patient. She had a quite weird and brief jerky movement, like together with a vocalization that respond to stimuli. She has a LATA, and we have a nice review from Dr. Lim Tien Tien that what is the LATA. And the LATA is the culture-specific syndrome characterized by exaggerate startle response. It might be together with echopraxia, corporaria, false obedience, maybe involuntary vocalization in response to startle. LATA is quite culture-specific and also first described in our region, in Malaysia and Indonesia. And that, in addition, is the various combination between the movement disorder, vocalization, psychiatric manifestation, and also behavior. Okay. And the last one is tic. Tic is defined as the intermittent, repetitive stereotype, and with premonitory sensation, and sometimes it can be partially suppressible. As you can see, tics are when they also have a repetitive, intermittent, and very stereotypic of movement. In one patient, they might have multiple pattern of tick, not only one. And each movement will repeat over and over again. With the premonitory sensation is like the urge to perform the tick. So they are might be volitional component, but actually they don't want to make the ticks in obviously, so they try to suppress the ticks for some period, and then they will have an urge to move again to make the tick again, and this is come over and over. And ticks may either motor or movement and or sound, which are motor, and we call motor tics and vocal tics. For the tics, it's most commonly in brief, abrupt, and in chronic pattern, but we may find the tic in slow pattern and sometimes prolonged. So the term is the tonic or dystonic tics, which can apply to the quite longer duration of each movement. So in addition, we subdivide tics into simple and complex. For the simple motor tics, is mean the movement involve only one group of muscle, and for the simple vocal tic is the simple sound without the articulation. And for the complex motor tics, which is the movement that has to coordinate the sequence of the movement, is involve many parts of the muscle. And for the complex vocal tics is like a linguistic meaningful utterance. And one thing that's important for the tics is the characteristic of the tics might be semi-voluntary movement, because they have the urge or the premonitory sensation to move, to have to move or have to make the voice. And sometimes it might be look like functional movement disorder too. And in addition, tics might be distractible and suggestible, that also found in the movement, in functional movement disorder too. And this is the example of the type of premonitory phenomena. They might describe that they have to urge or have anxiety or some pain, something want to move or to have a vocal, and it usually defined in the upper body part. And this is the example of tics. You will have the repetitive movement on his face, like repetitive blinking, sometimes sharpening eyebrow, his mouth, and actually he has a simple vocal tics too. And he has this movement from maybe the age of 15, and he was diagnosed with the Tourette syndrome, which is the combination of multiple motor tics and vocal tics, and it usually starts in adolescence and before the age of 18, and do not have other secondary cause. And this is a summary of the general feature of hyperkinetic disorder. In addition to, I talk about rhythmic, non-rhythmic, irregular, sustained or non-sustained. In the most common hyperkinetic movement disorder, actually we have a lot of other hyperkinetic movement disorder. For example, in the sustained group of hyperkinetic movement disorder, I will show you the example of the stiff person patient. And she's the old woman with acute onset of the slurred speech and steady gait, and with severe body stiffness with progressive. You will see that she has a marked stiffness of her axial, her leg, and sometimes superimposed with myoclonus, but that not show in this video. It's really stiff, like wooden, and her next is hyperextension. She was diagnosed of stiff person syndrome. Is also other hyperkinetic movement disorder. And another aspect that's also important is you have to consider that movement disorder occur during only daytime or during sleep or in both of time. I'll show you a little bit. And this old woman, she have a feeling of discomfort in her leg when she stay in bed in the evening time and need to move to relieve the sensation. Do you want to try to think about what the diagnosis of this patient? Yeah. I think you know that she has the restless leg syndrome. And the other one is the also nighttime movement disorder. It's not working. Okay. He is about 60 years old man, and his wife complained that he has a abnormal movement during sleep, especially in the early morning or second half of the night, and sometimes he shouted. You will see the jerky movement on his leg, trunk, and with vocalization. And the EEG and EMG also show that he in the REM sleep stage, which is the evidence of rapid eye movement. And without the EMG, but when he has the motor activity, this increase of the EMG activity during the REM sleep. So he is the diagnosis of REM sleep behavior disorder, which is one of the prodromal symptom of the Parkinson disease. And for the other feature, you should get to know to approach the other feature like the eye movement, the eyelid, hand and neck movement, gait, cognitive, facial, voice, and also stand and posture to get the whole information to approach one patient with one phenomenology or one movement. So before I end of my talk, this is a little bit take-home message that you have to identify this is through abnormal movement and what is the phenomenology that you can spot from the patient, and you can classify the movement disorder, the phenomenology, and the some clinical assessment of movement disorder. Thank you.
Thank you, Professor Chirada, for a good presentation of the topic movement disorder, phenomenology, and all of forms of Parkinson disease and dyskinesia, and about distinguish of the axis 1 or axis 2. Axis 1 is very important for history taking and physical exam, and axis 2 for etiology clearly and with video presentation. Thank you.
Okay, everyone. Can we start now the next session over this morning with the moderator, Dr. Bidayasiri and me. We move on to a very exciting and useful topic for all neurologists. How to approach, how to diagnose, and to manage Parkinson disease. And with my friend, the very well-known specialist on PD of Thailand and international too. You are international. I think this topic will be very useful for us, and particularly with the health and the knowledge of Dr. Bidayasiri. Thank you. Dr. Our speaker is now Dr. Lim Tien Tien from Malaysia. How to examine patient with Parkinsonism. Please, Dr. Lim.
Thank you, Mr. Chairperson. I'd like to take this opportunity to thank Prof. Rong Ruch, Dr. Jirada, and of course, Dr. Tai for this very kind invitation to this Indo-China conference. I also like to thank the organizers for such a warm welcome. And I'm very happy that I had fur and good coffee yesterday with Dr. Tai. So I'm going to start the next talk on how to examine patients with Parkinsonism. I'm a neurologist from Penang, Malaysia, with a specialization in Parkinson's and movement disorders. So, as you heard from the previous speaker on the phenomenology, the approach to examine patients with Parkinsonism, generally I would divide them into three categories. The first is during the examination, and I'm mainly talking on the physical examination, not about the history taking, to determine Parkinsonism. The second would be to look for red flags, or what we'll say as atypical signs in Parkinsonism. And the third is watch out for mimickers, things that look like Parkinsonism, but it's not. So in order to determine Parkinsonism, the four cardinal features, the bradykinesia should be have to be there, stiffness, the rigidity, the typical rest tremor, and postural instability. Look out for this, and you normally need at least 2 out of 4 of this to diagnose a patient with Parkinson's disease. But we'll talk about those atypical ones later. And we have things like flex posture and also freezing of gait. Next, we then look at the red flags, which are things like early gait instability and falls, which normally do not occur in patients with Parkinson's disease. Absence of tremor, that should ring a bell to say whether it is really those akinetic rigid type of Parkinson's disease or it's those atypical Parkinsonism. Careful with the eye movements. In the early stages, it may be very subtle, for example, like the saccade, the slowing of the vertical saccade in patients with progressive supranuclear palsy, cerebellar abnormalities, autonomic dysfunction, and look at their posture of the patient, whether there's any disproportionate anticolis or any contractures, stridor or size, dysphagia, axial signs like dysphonia, dysarthria, and also check for those cortical sensory signs, apraxia, looking out for myoclonic jerks and early dementia. The mimickers, I won't be talking in this lecture because I think it's a topic on its own and it's going to be long. So, but just watch out for things like essential tremor that you have seen in Dr. Jirada's lecture just now, pyramidal tract lesions, depression, hypothyroidism, and psychogenic Parkinsonism. So, this is a patient that I saw early this week. And I think this everyone will know is a very typical patient with Parkinson's disease who walks into the clinic, you see the faces, you see the posture, you see the typical rest tremor, and you know that this patient has Parkinson's disease. And you're quite happy that you make a diagnosis there and there as the patient walks in. But there is a very interesting article that was published in 2018 in Practical Neurology, where it mentioned that maybe even before the patient walks in, we could have idea of what the patient may be having or what the diagnosis is at the waiting room. And sometimes as we go into the hospital, we see patients walking into the main entrance or walking along the corridor, and you may think, hey, is this my patient that is coming in? And you look at the behavior of the patient, We look at the sitting posture of the patient, and we look at even the clothing and the accessories of the patient. And this is an article that is worthwhile going through and reading it. I just point out a few of the points here. For example, if you see a patient with bruises, injuries over the face, and you may think that this is early or marked postural instability in a patient with atypical Parkinson or progressive supranuclear palsy. If you see a patient just diagnosed recently, or you have just diagnosed it and the symptoms occurred like maybe a year ago, and is on a wheelchair by now, and he has features of Parkinsonism, perhaps we are dealing with atypical Parkinsonism with early falls and postural instability. If you see a patient who is dozing off in front of your clinic, watch out. Is it because we have given the patient dopamine agonist that is too high of a dose, any sedative medications because previously patient could not sleep, or the patient had a poor nighttime sleep quality? So these are the examples of what we look at in a patient with Parkinsonism. Restlessness, dyskinesia, whether we are dealing with akathisia, drug-induced Parkinsonism, or dyskinesias. Okay, so to determine Parkinsonism, as I've mentioned in the first slide, the first four, bradykinesia, rigidity, tremor at rest, and loss of postural reflexes, plus the freezing motor blocks and also the flexed posture. We normally use the 2008 Movement Disorder Society Unified Parkinson Disease Rating Scale, and the motor part is the part 3 motor examination. If you can see from this scale, the ones in the red box are is the part 3, and it focuses on the speech, the facial expression, rigidity, bradykinesia, gait stability, and tremors, which what I have mentioned just now, except in a more detailed manner and in a way to scale it so that it becomes more objective. As you know, we do not have a real biomarker in a patient who has Parkinson's disease. So I'm just going to show you an example of this video, but this video is not a full video of the examination. I had to cut it short because of time consumption. So for example, if you see the eye movement examination, it shouldn't be that simple. You should actually carefully examine the saccades, examine the pursuits. But you can see that this patient has the typical right hand resting tremor. And you would want them to count backwards, maybe say the months of the years backwards from December to January. If the sound can be on. Then you look at the tremor at posture and just wait a few seconds to see for re-emergence tremor. Look for bradykinesia with finger taps, hand grips, pronation and supination. And then check the lower limbs, the foot tapping as well. And always compare both sides, the right side and the left side. Typically in Parkinson's disease, one side should be more severe than the other side. And the most important one, the gait examination. Look at the posture, look at the stride length, look at the arm swing. Look at how the patient walks. Then the pull test. We'll always warn the patient before doing this test and tell them that they should take large steps backwards and at the maximum 2 steps backwards. And make sure that something is behind you so that you don't fall together with the patient. Look for cerebellar signs, measure the blood pressure, supine and at the erect standing position. So just a few highlights. I won't go through the whole Unified Parkinson Disease Rating Scale. For example, in facial hypomimia, you look for the mask-like faces and whether the lips are parted sometimes when the mouth is at rest, and that would be a category of mild, which is 2, and moderate. You can see this patient with associated dermatological seborrhea, if Parkinson patients, decreased eye blinking, masked faces present in the lower face as well, namely fewer movements around the mouth, such as less spontaneous smiling, but the lips are not parted, so this becomes a 3. So sometimes the faces can tell us more than whether it's Parkinson's disease or a normal patient, but it can also tell us that there are maybe features of atypical Parkinsonism, and they don't look the same. So if you can see A, so this is from PRDs in 2019. A patient with mask-like faces in Parkinson's disease. But if you see B, it's actually a different faces of patient with progressive supranuclear palsy. You can see the vertical muscle, the corrugators, and the procedural sign. And in C, you see a reptilian stare in a patient with PSP. D is a patient with blepharospasm. So you can see a bit of contraction around the orbicularis. And E, a patient with apraxia of eyelid opening. And F, orofacial dystonia in a patient with MSA. So in bradykinesia, we not only look at finger tapping, we look at the other features as a whole in a patient as the patient enters the clinic and as the patient, and we examine the patient. We look for decreased facial expression, slowness is movement, as you can see in this patient. And we look at the small handwriting. So you can see as this patient, he has not only slowness in writing, but the tremor comes in when she writes. This is the finger tapping. Should be done in all patients with Parkinsonism. And hand grip movements. And the soft monotonous speech. Perhaps very soft until you can't hear it now. Okay. There is an article from the brain that says that there's one feature that may be useful sometimes where when you check for the finger tapping, you look for also decrement. Means that in patients with Parkinson's disease, you may notice that in the initial part of the examination, the amplitude may be quite wide, but as it goes, after a few seconds, it becomes smaller and smaller. But in patients with atypical Parkinsonism, for example, in PSP, they may not have the decrement because it starts slow from the beginning. So it's slow all the way, as opposed to this one, where you can see that it's quite big and then it becomes very small, although it may be fast in frequency. Similar for the handwriting, in PSP, they may be already small handwriting and they write throughout the sentence, it's small. Whereas if you can see in a patient with Parkinson's disease, sometimes it's quite normal at the beginning, and as you write more, it becomes smaller and smaller. Another thing not to be missed is the rigidity, and I just highlight one point that when we check for rigidity, remember sometimes the rigidity when they come in is quite mild. So you may need to do it with activation maneuver. Perhaps the other arm asks them to do something, some pronation, supination, or hand grips, and then recheck the rigidity. So if it's so slight, you may actually, with activation maneuver, then it's actually classified as 1 in the UPDRS score. Okay, next we come to tremor, and this is a consensus statement of the classification of tremor from the Task Force on Tremor in the International Parkinson's and Movement Disorder Society. And we look at tremor characteristics, meaning that we look at the body distribution. And in Parkinson's disease, normally the upper limb predominant, you get tremor, which is asymmetrical, worse on one side, resting 4 to 6 hertz style tremor. And then you do activation conditions and look at the tremor frequency. And in Parkinson's disease, the tremor frequency is not as high normally as the tremor frequency in essential tremor. So for the activations of tremor, you look at whether it's rest and action and whether it's kinetic, postural, or isometric tremor. So you get used to this tremor in the patients with Parkinson's disease. Relatively high amplitude in this patient, low frequency at rest. And as the patient counts backwards, or as the patient says the months of the years backwards, you can see that the tremor increases. And then when he lifts it up, the tremor almost disappears. Sometimes you see patients, a lot of times people refer, other consultants may refer as a tremor, but if you look carefully, they may not all be a tremor. And I just show you these two cases where they are very jerky, smaller amplitude compared to the ones you saw, but you see that jerky component in these two patients.
Oh, okay.
So you want to call it jerky tremor, or you want to call it myoclonus. But this is more common in patients with multiple system atrophy. And if they have predominant Parkinsonism, MSAP, which happens in up to about almost 50%, as compared to Parkinson's disease, which is only about 6% from the study. So the pill rolling tremor in Parkinson's disease is actually rare in MSA. The tremor, or so-called tremor in MSA, is often higher frequency, lower amplitude, sometimes jerky, maybe stimulus sensitive, and has a myoclonic component. So we sometimes call it as a mini polymyoclonus. Another thing about tremor, that when we examine the tremor and as we ask the patient to lift up, don't do it too fast, just wait for a few seconds. And sometimes you get a tremor frequency which is almost equal to a resting tremor of a Parkinson's disease patient. And we call it a re-emergent tremor. So this is about 3 to 5 hertz, like what the resting tremor is. And it may have a relatively good response to dopaminergic therapy. So you can see in this video, you do see the resting tremor here.
Good. Can you hold your hands straight out for me? Yeah.
No tremor. And then after a while, the tremor comes up. And the frequency is almost the same like the resting tremor. So this is a re-emergent tremor. Next, we go to the fourth one, which is posture. So posture in a patient, we know the typical stoop posture in Parkinson's disease. But if you have a patient with anticholis or retrocholis, always think again. And in this patient on the left, anticholis has an MSA and a retrocolic in PSP. Other abnormal posture would include things like camptochomia and PISA syndrome. So camptochomia is a marked flexion, normally more than 45 degrees at the thoracolumbar spine. And when the patient lies flat supine, it goes away. So the posture becomes almost normal when she lies flat. And this occurs in about 26% in MSA, which is more common than PSP and Parkinson's disease. In PISA syndrome, you have a lateral flexion of about 10 degrees or more of the spine, and also abates when at a recumbent position. And also it's more common in MSA. This is just to show you again, loss of postural reflex and the pull test that you have seen before this. So be careful, like if the wall was not behind me, I may actually fall together with him. And always warn the patient before. And this test, I would say the patients are normally very fearful. So you have to tell them and warn them much way before you pull them backwards. So this is a home video of one of my patients. And this is just to show you gait assessment. So when we look at the gait of a patient, we look at a few parameters. Number one, we look at the speed of the gait, how fast the patient is walking. Number two, we look at the step length. The third, we also look at the arm swing of the patient, and we look at it bilaterally, and also we have to determine whether one side is worse than the other. We look at foot clearance, and we look at how the patient turns. So you have to do the patient walking a certain distance and then turn back as well. So you can see he has this stoop posture. You can see the facial hypomimia, the reduced arm swing, which is more on the left compared to the right, a very small stride length, and a bit difficult in clearing the foot. And as he turns, a bit of freezing over there, and then he tries to turn with a few steps, and then goes backward. So now he sees the box, the box on the floor, and the stride length becomes slightly better. So that is sort of a visual cue in this patient. So similarly, in this patient, with freezing, He freezes so badly that he cannot even lift up the foot to take a step forward. But freezing of gait is amazing in the sense that with the visual cue, you can see how amazing he walks now. So there are ways to help in the management of this. And if you need more devices like the laser cane and all that, I think Rong Ruch has a whole set of it now and very upgraded by now. So we look at other Parkinsonism condition with gait disorders, and not all of them looks like Parkinson's disease. So you can see that this one is a bit broader base compared to the previous video. And you can make a guess that this patient doesn't have Parkinson's disease, but has an MSA. The second one, you can see a bit of sway, a medial lateral sway, and also wide base gait in a patient with Parkinsonism. And this is a patient with progressive supranuclear palsy, PSP. The third one, a patient with gait apraxia, has very difficulty even lifting up the foot, and as you can see, his daughter sort of becomes very impatient. Why can't you just take a step forward? And he slides the whole foot, and that makes him cannot walk at all. And he responded very well to VP Shan. He's a patient with NPH, normal pressure hydrocephalus. And sometimes you see a patient that has predominant lower limb Parkinsonism, but the upper limb is almost very slight Parkinsonism features. It's a patient with vascular Parkinsonism, so lower body Parkinsonism. So this is from the same article just now, BRD. You look at the footfall patterns. They are a bit different. They are different actually. In PD, you get the narrow-based characteristics. You can get some freezing of gaits in between. But in MSA and PSP, in MSA, a lot of times you see them broad-based, and in PSP, broad-based with the increased medial lateral sway. Also, another thing important when we do our examination, when the patient comes to the clinic, is that we have to look at the timing when the examination is done in relation normally to the medication, the levodopa that the patient takes. And as you can see, this patient, when he comes in, he has minimal Parkinsonism features, but he has choric movements, or what we call as dyskinesias, oral, lingual, even at the cervical region, and also the upper and lower limbs. So that's because it's at the peak dose of his levodopa, and he came in with a peak dose dyskinesia. But we wait long enough, the examination. Now all the Parkinson features come in. He has this rest tremor, he has the rigidity, he has the slowness, he has the typical resting tremor. So the timing is important, because if you do a unified Parkinson disease rating scale 3, you'll find that the scores are different when you do it when a patient is on or when the patient is at off. Okay, we move on to atypical signs and red flags. So features predictive of atypical Parkinsonism, the ones highlighted in blue are most of the time the ones that we need to examine. So we look for gait instability and falls early. Absence or paucity of tremor, irregular jerky tremor or myoclonus, which you have seen. Additional features, the eye movements and the cerebellar signs are important. Then you watch out for things like the stridor, dysarthria, dysphonia, the apraxia, alien limb and myoclonus in corticobasal syndrome. And always do a test, maybe probably a Montreal cognitive assessment to determine whether the patient has dementia and how many years has it been since the patient has been diagnosed to have Parkinsonism. So the eye movements, I would say that majority of the time, the abnormal eye movements would be in cases of PSP, progressive supranuclear palsy, where they may have slowing of the downward saccade, supranuclear gaze palsy, the vertical eye movements, round of Hauser signs, square wave jerks. In MSA, you may have gaze evoked downbeat and rebound nystagmus, and you have may have impaired smooth pursuits. So this is an example of a square wave jerks. You ask the patient to look far, and you see this saccadic movement. And the second one, you have a patient, also a bit of horizontal gaze palsy, which comes in normally later as compared to the downward gaze palsy. And you do a corrected dulse, and normally when you move the head backwards dulse, the eye can actually come down. Cerebral abnormalities, dysmetria in this patient. She was diagnosed as Parkinson's disease before seeing me, and came in with almost a near syncopal attack because her blood pressure dropped to almost about 70 because of challenging of the levodopa dose. And we know that in MSA, if especially not the early period, they do not respond that well as compared to Parkinson's disease. So too much of levodopa, she developed postural hypotension. But when you see this type of patients, you may not be dealing with Parkinson's disease, but probably MSA. Another interesting sign that you may want to just be part of your examination would be what we call as the applause sign. And applause sign is somewhat a perseverative behavior where the patient continues doing the applause because we are testing on hand clapping. And this may suggest a severe frontal subcortical or caudate dysfunction. So you ask the patient to clap 3 times.
No,
and they
just 3
continue
times.
doing it more than 3 times.
Okay, so in one setting, just 3 times. In one go, clap 3 times. 1, 2, 3. No.
There is 4 times he claps. So it's
Can you do
sometimes
it one more
helpful to
time,
discriminate things like PSP from FTP and Parkinson's disease.
Thank you.
So besides the motor examination, the cognitive and behavior examination is also somewhat important. Always do a Montreal cognitive assessment would be a more sensitive test as compared to the mini mental state examination. The frontal lobe dysfunction, you may want to do a frontal assessment battery, and then look for aphasia, speech apraxia, mood assessment. As we know that depression is very common in patients with Parkinson's disease. Look for emotional lability, obsessive compulsive disorders, hallucinations, and delusions. So if you see a patient like that coming into the emergency and has been diagnosed with some form of Parkinsonism, the stridor, I always think of multiple system atrophy, MSA, and that's the contractures in a patient with MSA. So they may get more dysphagia, more stridor. Sometimes you get pyramidal signs, hyperreflexia, Babinski, enterocolis, and striatal deformity or contractures. So the theory is either the neurogenic atrophy of the posterior cricoarytenoid or the dystonia of the adductor muscles. So if you suspect a patient may have atypical Parkinsonism and it's asymmetrical, you may want to ask them to do certain tasks. For example, show me how you brush your teeth, or show me a peace sign, or show me a love sign or something. And they can't do that movements on one limb. For example, in this lady, she has very difficult motion on the right side. She thinks that the limb doesn't belong to her anymore. So this is a patient who had corticobasal syndrome. So I come to my last slide. And so in summary, the examination based on the goals of 3, which I mentioned. Well, number 1 is to determine Parkinsonism, looking for bradykinesia, rigidity, resting tremor, look at the posture, look at the gait of the patient. Second, after you have determined Parkinsonism, look for red flags or signs to suggest atypical Parkinsonism, which I've showed you just now. And the third one is that do not miss things like mimicus, some things that look like Parkinson's, but it's not. Second is the observe carefully while taking this history, so you can save a lot of time because you have already done a lot of the examination while taking the history. It means you do it both together. And third is always examine the gait of the patient. And sometimes with good technology now, a lot of signs or things may happen at home, but because we are with the patient for maybe only 10 minutes, 15 minutes, we don't see the features at home, and a lot of time the relative will show you, hey, can you just have a look at this clip that I took with my handphone? And I find that very, very useful and important, because when the patient comes to the clinic, they may be a different time, they may be on an on period, they may have mild dyskinesia, but at home it's different. So always look at the home videos also. So with that, I hope you enjoyed the lecture on this topic, how to examine a patient with Parkinsonism. Thank you very much.
Yes, that's quite an impressive video collections. Tian, thanks very much. Probably we have time for one quick question. Any question at all? So, Tian, maybe I could ask for your tips really, because there are a lot we can do with the examinations, but I just want to ask in your own practice, when you have a short period of time, what would be your tips to quick examination to determine whether that patient has Parkinson's disease over other atypical Parkinsonian disorder?
Thank you for that question. So yeah, I mean, I was talking to Tai and said, how many patients do we see a day? Sometimes we see 40 to 50 patients in a day. And to really thoroughly examine one patient for 30 minutes is quite impossible unless we decide to go back at midnight. And the day continues the next day. So there are certain tips, I would say, that we look for in a patient to look for atypical Parkinson as compared to Parkinson's disease, because that would actually change the prognosis and also the treatment for the patient. I guess the first thing is like what I mentioned, is to look at the faces and how the patient walks in. But the second tip would be, if you see a patient that has been newly diagnosed or has only had symptoms for maybe a few months or less than a year or within 3 years and is on a wheelchair, that triggers me that this cannot or is quite rare to be Parkinson's disease to be on a wheelchair, unless of course she has other reasons like maybe osteoarthritis of the knee together with Parkinson's and so on. So on a wheelchair. The third is to determine whether the patient has been treated by other physicians or neurologists or movement disorder specialists and on a relatively high dose of levodopa, and they do not respond that well, or the family is still not happy with the outcome of the treatment, then you think again, are we really dealing with atypical Parkinson? So, I mean, normally we say about 800 milligrams to 1000 milligrams of levodopa, and still the patient is having a lot of stiffness, rigidity, bradykinesia. And of course, and the asymmetry of it, you don't really see the asymmetry and the absence of tremor. That would also trigger me to point out to atypical Parkinson's. And I guess the rest I've shared in the lecture.
Thank you.
Thank you.
Thank you very much. So let's go to the next session. I think we cannot have the topic in the movement disorder conference without the topic on Parkinson's disease. And this topic is going to be given by the person here who does not need any introduction at all, Professor Tai Tran. He will deliver the lecture on Parkinson's disease diagnosis and therapeutics concept. Welcome, Dr. Tran.
Thank you, Professor Virajasri, for your introduction. Good morning, everyone. Now I would like to share with you the topic Parkinson disease diagnosis and therapeutic concept. I don't have any disclosure for this topic. At the beginning, I would like to share with you some clinical case. You can see here, this is the male with 56 years old. He suffered from the smell loss for 2 years, and 1 year later, he suffered from the slow movement and mild tremor on the left side. On examination, which is he has a nosmia and left side Parkinsonism with GBD at past 320. He is diagnosed with early Parkinson disease, and you can see here, this is the woman. She suffered from slow movement and mild tremor on the right hand, and she also diagnosed with mid-stage Parkinson disease. And this is the third case. He suffered from Parkinson disease for 12 years, and now he have freezing upgrade and have dyskinesia on medication, and he diagnosed with advanced stage of Parkinson disease. So you can see Parkinson disease is chronic progressive neurodegenerative disease, and clinical manifestation include rest tremor, rigidity, bradykinesia, and postural disability. The mean of age of onset is 65, and it affects 1% of the patient more than 60 years old. This is the map of the prevalence of Parkinson disease in the world. You can see the prevalence varies by region to region. So in our region, you see the prevalence about 80 to 100 per 100,000 population. And this map is shown by Professor Virajasri, and you can see the picture of our region, Indo-China region. How about the neuropathology diagnosis? As you know, neuropathology diagnosis is still considered as a standard of the diagnosis of Parkinson disease. And in this pathology, you can see compared to the normal people, the Parkinson disease people will have the loss of pigmented substance compactor, and they also have the loss of dopaminergic cell, and in the cell survival, there are the presence of Lewy body and alpha-synuclein, and that is the standard for the diagnosis of Parkinson disease in pathology. So how about the pathological progressions of Parkinson's disease? You know, according to hypothesis of Parkinson's disease, we will have 6 stages. In the stage 1 and stage 2, the pathology effect on the oblongator medulla, and the effect on locus coeruleus, and also 9-10 nucleus. And that stage in the clinical is the prodromal syndrome. And when the disease progresses to the stage 2 and stage 3 and stage 4, the motor symptom begin. And you can see here the pathology effect on the mesocortex and substantia nigra. So that's why the motor symptom occur. And to the stage 5 and stage 6, you can see the pathology effect on the neocortex. So some symptoms such as dementia, such as possibility postural instabilities appear. So that is the symptom resistant to levodopa. So how about the clinical progression? With the paradox hypothesis, you also see the timeline of progression of Parkinson's disease in the clinically. You can see here in the statue of hypothesis, we will have the prodromal Parkinson's disease, and at that stage, the motor symptom, we don't have a motor symptom. And when we in the early stage of Parkinson's disease, the motor symptom, bradykinesia, rigidity, tremor appear. And when the patient move to the middle stage, and some motor complication appear. And when the patient move to progress to the late stage, we can see the postural disability and falling, freezing, dementia will appear. So that is the progression of the motor symptom in Parkinson's disease. And how about non-motor symptom? In Parkinson's disease, you know, non-motor symptom also very important for the patient. So you can see the non-motor symptom can appear every time of the progression of the disease. At the prodromal stage, we can see some REM sleep behavior disorder. We can see constipation, depression, and after that, we can see autonomic dysfunction and cognitive impairment. How about the survival of Parkinson's disease? You can see in this chart the survival curve of Parkinson's disease when we compare the Parkinson's disease patient with the reference group. You can see in the first 5 years, the survival is the same between two groups. But after 5 years, the patient with Parkinson's disease will have the lower of survival compared to the reference. And at the after 15 years after the diagnosis of Parkinson's disease, we can see the patient with Parkinson's disease will have 3 times lower than in reference group with survival. So how we can make the diagnosis of Parkinson's disease? We are the neurologists, we are the doctor. We can see the progression of Parkinson's disease for a long time. When we catch up the patient at the prodromal Parkinson's disease, how we make the diagnosis. And when we catch up the patient at the early stage, the middle stage, and the late stage, how we make the diagnosis. At the early stage of Parkinson's disease, we also, we have many criteria for the diagnosis of Parkinson's disease. So this is the criteria we usually use. That is recommended by MDS. In this criteria, we need to have the essential criteria for the diagnosis. At first, the patient must have a bradykinesia, and the patient also have the combination of at least one of rest tremor or rigidity. When the patient have a bradykinesia and rest tremor or rigidity, the patient will enough for the essential criteria for the diagnosis. And after that, we will diagnose the patient with clinical established Parkinson's disease. We need to check to examine the patient to rule out the absolute exclusion criteria. The patient also don't have any red flag, and the patient have at least 2 supportive criteria. At that time, we will make the diagnosis of the patient with clinical established Parkinson disease. And how about the clinical probable Parkinson disease? We will make the diagnosis when the patient also have no absolute exclusion criteria, and the patient will have the presence of red flags, counterbalance by supportive criteria. That means if the patient has 1 red flag, they have at least 1 supportive criteria. This is the absolute exclusion criteria. You can see there are 9 features. I think we can checklist in the paper to check the patient with Parkinson disease must don't have any feature of this exclusive criteria. And we also check the red flags. This is 10 red flags. So we must checklist and to rule out the red flags when we want to examine the patient with Parkinson disease for the clinical establishment. And this is a supportive criteria. Yes, we have 3 supportive criteria for the diagnosis of the patient with early stage. Yes, rest tremor of a limb, the presence of either olfactory loss and cardiac sympathetic denervations on MIBG scintigraphy, and the patient also respond very dramatically and clearly to dopaminergic therapy. If we catch up the patient at the late stage, the middle stage, how can we do diagnosis? So we also use this criteria, but you must review all the absolute exclusion criteria and review all the red flags, because at this stage, maybe the patient will appear the red flag, maybe appear the absolute exclusion criteria. So we must review the patient. We will re-examine the patient again to check, to rule out it. And how about the supportive criteria? Besides 3 features I have talked, we also check the patient with the presence of levodopa in induced dyskinesia. So if the patient have more supportive criteria, we will have an opportunity to make the diagnosis. What is the clinical diagnosis accuracy for this criteria? You can see this is the clinical study. Yes, and the study showed us the overall accuracy for probable Parkinson disease were 92.6%. So you know this is a clinical study. The gold standard for this studies is the experts movement disorder expert role. So I think we need another study, the clinical pathological study to validate this criteria. And what is the accuracy between the early and advanced Parkinson disease diagnosis? As you can see, in the early Parkinson disease, the accuracy of diagnosis is lower. For in this studies, it shows just 53% compared to the advanced Parkinson disease. In advanced Parkinson disease, the diagnosis is better. And you can see 88% of the patient with Parkinson disease can diagnosis exactly in the advanced stage. So, and how about the prodromal Parkinson disease diagnosis? When we catch up the patient here, how we make the diagnosis? You can see this is just research criteria for the prodromal Parkinson disease. That's also updated by MTS in 2019. And but you know, this is just the research criteria. In this criteria, we must do 3 steps. The first, we must estimate the prior probability, and the second, we calculate the likelihood ratio marker, and the third, we estimate the post-test probability. With the prior probabilities, we estimate by the prevalence. For example, if the people at the age of 50 to 54, the prevalence of Parkinson's disease at this age is 0.4%, and with the age more than 80 years old, the prevalence is 4%. So that means the prior probability. And then we must looking for all the risk marker and all the prodromal marker. For example, if the patient is male, the likelihood ratio positive is 1.2, and if the female, the likelihood ratio is minus 0.8. And if the patient have the first relative for Parkinson's disease, and the likelihood ratio is positive 2.5. And how about the prodromal marker? If you find that the patient have the REM behavior disorder proven by polysomnography, and you can see the likelihood ratios very high, positive for 130. And then we multiply all the risk marker and all the prodromal marker together. So on this diagram, monogram, you will have the pretest probability here, and we will have the likelihood ratio here, and we draw the line, and we can have a post-test probability. And probable prodromal Parkinson disease would refer to the high likelihood with post-test probability more than 80%. We also have the calculator for calculate the prodromal risk for Parkinsonism on MDS website. We move on the treatment of Parkinson disease. As you know, Parkinson disease still remains a progressive disease without a cure, and the disease modifying therapy has continued to fail. Symptomatic treatment are highly effective in clinical. So when we see the timeline of the progression of Parkinson disease, we also have the timeline of the treatment of the Parkinson disease. For example, at the preclinical Parkinson disease, we can manage the non-motor symptom, but without motor symptom. And we also don't have any disease-modifying therapy. But at the early stage, we can use medication to treat the motor and non-motor symptom. But when the patient have a motor complication, we began to consider the invasive therapy, such as apomorphine infusion, LCIG, levodopa intestinal gel infusion, or different stimulation. And when the patient have the delay stay, and we recommend stronger with the invasive therapy. But if the patient very late, at the very late stage, we cannot use invasive therapy, and and medication will also reduce gradually. At that time, the patient will be disabled. At the early stage, we have the guideline for the treatment at the early stage. This is the American Academy of Neurology guideline in 2021. At this guideline, when the symptoms are not causing disability, most individuals in Parkinson's disease and clinicians are comfortable with a wait and see approach. However, careful monitoring and advising the patient do not tolerate the disability or reduce the quality of life unnecessarily. But when we need to use the medication for the patient, which medication you choose at the early stage, we can choose levodopa, dopamine agonist, or MAO inhibitor. With levodopa have the greatest benefits, but levodopa also have more dyskinesia. But with dopamine agonist have the moderate benefit, but dopamine agonist also have the high risk of impulse control disorder, ICD, and with MAO inhibitor is with benefit. So there are some features to prior to choose the medication. For example, with levodopa, we can choose levodopa for the patient more than 70 years old, and for the male sex, for cognitive impairment, psychosis, overweight, history of ICD or addiction, and we can use the dose less than 400 milligrams per day. With dopamine agonist, we can use for the patient younger than 60 years old. The female sex, the patient don't have no cognitive impairment, no psychosis, lower body weight, no history of ICD or addiction, as no excessive daytime sleepiness. And with MAO inhibitor, we can use for the patient with mild symptom, mild motor symptom. And how about anticholinergics? We also use anticholinergics only for tremor. You can see on this review, the author suggests to use anticholinergics for the only tremor. And you can see anticholinergics also using for many countries now, up to now. And in the advanced stage, how do we treat the patient with the advanced stage? At the advanced stage, the motor symptom will have more. So this is a guideline. This is the update for the treatment of Parkinson. For treatment of motor symptom of Parkinson disease, you can refer. And you can see there are many kinds of medication for Parkinson disease up to now. We have levodopa group with levodopa oral, levodopa inhaler, levodopa infused in gel infusion, and we also have a dopamine agonist for oral, for parts, and for injection for sublingual. And we also have a zonisamide, AOB, MAO inhibitor, COMT inhibitor, anticholinergics, anti-NMDA, and adenosine antagonist. However, you see the picture, the slide of Professor Pedasasari. In our region, we have levodopa. Most of countries have levodopa, and most of countries have a different stimulation. but another some country have, some country no. So when the patient from the early stage to the middle stage, the patient will have some uncontrolled symptom. So at that time, we can increase levodopa more than 400 milligram per day, or we can increase the dose of dopamine agonist, and we also a combination of medication. When the patient have motor complication, we also adjust levodopa. We also use polytherapy, and we also use invasive therapy. With invasive therapy, we can use apomorphine injection, or LCIG, or functional neurosurgery, deep brain stimulation, listening, focus, ultrasound. How about the non-motor symptom? You know, non-motor symptom also very important, and the patient all the timeline of the progression, you can see many non-motor symptoms. So you can use the updates of treatment for non-motor symptom of Parkinson disease on MDS guideline, MDS review in 2019. So we can see can do it, and we also use rehabilitative therapy for all the symptoms and all the state of Parkinson disease, such as do exercise, physical therapy, occupational therapy, and speech therapy. And I summarize the progression of the treatment of Parkinson disease from the early stage. We can use levodopa or non-levodopa. And on the advanced stage, we can use levodopa modification or polytherapy adjustment. And when the patient have a motor complication, a motor fluctuation, we can adjust polytherapy. And when the patient have the dyskinesia, we can also adjust polytherapy, and we can add amantadine or clozapine. And after that, we can use invasive therapy. At the same time, we also manage the non-motor symptom, and we also use non-pharmacological therapy for the patient. In conclusion, you know, Parkinson disease is a heterogeneous and complex integrity. The diagnosis is very challenging for some cases, and current therapies manage the symptom effectively and improve the quality of life for the patient. And we also need more clinical trial with disease modifying therapy. Thank you very much for your attention.
Thank you, Dr. Tai, for your comprehensive talk on the diagnosis and management of PD. Any question, please? Professor Gao.
First of all, I would like to thank you for very useful presentation. And I have one comment and one question for you. Several years ago, we had a trial to use nilotinib to stop the progression of Parkinson disease. But then we had to stop our trial after the information from Pagan and his co-worker from United States that that nilotinib is not effective on Parkinson disease progression. It was a very disappointing information for us, but we have to agree with him and with you too. Thank you. We have no nowadays no cure therapy and no modifying treatment for Parkinson disease. And I would like to have a question for you. Thank you for your case presentation about anosmia and how to differentiate between anosmia with Parkinson disease and with Alzheimer disease. And if you have some devices to test the anosmia in Parkinson disease. That's all.
Thank you very much for your question. With anosmia, with me, I can differentiate between the anosmia in Parkinson disease and Alzheimer. But some studies show that in Parkinson disease, in anosmia, maybe have the patient will have the loss of the smell for some order, and in Alzheimer, the patient will have the loss of other orders. So a little bit different between two groups, but in clinical, with me, I can differentiate between them. Thank you.
How about your opinion, Professor Rongroy?
Right. So probably we don't utilize the smelling function as a primary tools to differentiate Parkinson disease from the Alzheimer's. I think that to get the information from both group of patients can be quite challenging a bit, and I think that it's also depends on the cultural and their background influence too. I believe that our group, Dr. Chakota, she did quite extensive work on this smelling function and also gustatory function in patients with Parkinson's disease. She found some disturbances in patients with Parkinson's, but she also identified some regional influence of these recognitions of various smell and taste perception too. So I believe that you will find the abnormality, whether it's sensitive enough to distinguish between the two. I'm not quite sure. We don't use it primarily because other clinical features probably they are more sensitive to differentiation.
Any other question? I think that many attendees are waiting for some more comment from Rongroy about this topic. Do you have some more comment?
Yes, I mean this is like a like a bread and the butter of our movement disorder practice, that we need to recognize these Parkinson's. But as Professor Tan has outlined, that it is still a challenge to diagnose early Parkinson's in clinical practice. And the number that you demonstrated, I think, is reflected very well that accurate diagnosis of early Parkinson's is not easy at all. Maybe you can share your tips again if I ask for the tips for examination or detecting early Parkinson's disease in your practice. What would be your clinical clues to for early patients?
Thank you. In my clinical practice with the patient at the early Parkinson disease, when I examine the bradykinesia, rigidity, and rest tremor on one side, I also to check all the non-motor symptoms, especially anosmia. If the patient have anosmia, we will increase the opportunity to make the exact diagnosis. And we also check all the non-motor symptoms. For example, REM behavior disorder, the generation, the relative with Parkinson disease, etc., and all the symptoms help us to make the diagnosis of early Parkinson disease exactly. That is very important in clinical. But there are some imaging can have, but in my country we don't have. For example, dopaminergic imaging or ultrasound, etc. We don't have. Thank you.
Okay, no more questions. Then I think we have to move on now to the video session. Dr. Lim Tien Tien and Dr. Lê Uyên, please.
I think the video session will be a bit more the fun part, isn't it? So maybe we could do a bit more interactive. The audience could participate, and maybe we all can join in with thoughts and forth and on the cases you're going to present. Thank you.
Yeah, thank you. So good morning, everyone. I'm Uyên Hà. I'm from University Medical Center, and firstly, I'd like to express my gratitude to the organizing committee to let me have a chance to stand here. And this is my very first time to present in front of so many audiences and so many renowned experts. So please excuse me for any mistake there may be. In the first part of this session, I discussed two cases. My first case is on 37-year-old male who experienced initial symptom in 2017. He got a diagnosis of PD and was put under treatment in 2018. And since 2020, he has had multiple complications, including fluctuation and dyskinesia. In more detail, in 2017, the patient initially noticed his slow walking and forward flex posture. 8 months later, he experienced progressive stiffness of his right leg, and at that time, he got a diagnosis of young onset Parkinson disease and received treatment. In now the first 2 years, he reported a good response to the medication, but later he noticed a gradual decrease in duration of benefit from each dose, which resulting in medication increase. And as a consequence, dyskinesia also appear. To control the multiple complication, the medication adjustment, including levodopa fractionation and increase in dopamine agonist dose, was made. And in the beginning of this year, he came back to our clinic, and his caregiver told us about his strange behavior. He kept buying many unnecessary things. He became addicted to online gambling, which then led him to much debt. And he also admitted that he had an increase in sex drive. And when he looking up for information online, he knew about the side effect of pramipexole, and he decided to stop using it for a week on his own. And after that, his motor symptoms rapidly got worse, and he had to get hospitalized. And this is the medication, the latest prescription. Before he stopped using pramipexole, he had levodopa, carbidopa 6 times a day, half a tablet, pramipexole ER 4 tablets a day, and he also used amantadine twice a day. So as the recommendation from the chair, so is there anyone want to comment on this patient?
Okay. You can ask for the volunteer first, of course, but if there are no volunteers, you have the privilege to pick who you like to discuss. What about that?
Okay.
What would be your question, though? What is your question to the volunteers?
So, do you have any comment, or do you recommend any diagnosis for those unusual behavior of the patient?
So maybe, what are the symptoms and how would be the management, isn't it?
Yeah.
All right. Okay. I need to stand up and walk a bit, I think. Otherwise, I'm going to go, having daytime somnolence too. So any volunteers? Yes. Thank you. Thank you very much. I think the neurologist from Hanoi, right? Okay. Thanks so much.
Okay, thank you very much for the case. I think the patient have ICD, invasive obsessive disorder, and that's why he need to stop pramipexole, and we can increase levodopa, and we use together with amantadine, because amantadine will help with the dyskinesia, and the patient can be also the good candidate for DBS, I think so.
Yeah.
Thank you.
Thank you.
Thanks so much.
Yeah, due to the severe motor deterioration, so he came to our hospital and he had to got hospitalized. And this is the video of this patient. This video is recorded during his off state. So as you can observe in those videos, the patient had a bilateral severe bradykinesia, more prominent in lower limbs. He barely moved his leg. This is what he do when we told him to stand up. He cannot stand up on his own.
Cố gắng để coi như thế nào. Đứng lại vậy nè, cố gắng lại vậy ha. Thì có người đỡ vậy hay thử có nổi không nha. Được không? Được ha, đợi. Đứng vậy ha, rồi đứng vậy giùm em ha, thử có nổi không.
He need the assistant to stand up. This is his gait, and he has a pulse test. He can recover on his own. He raising his leg while walking. So when we assess this patient, the MDS-UPDRS scale resulted 7 in part 1, 13 in part 2, 51 in part 3 during off state, and 43 in on state. And the part 4 resulted 7 years old. He had a normal cognition, no depression. And to assess the complaints of the patient and his caregiver, we use the QIPRS diagnostic tools recommended by MDS, and we found 2 behavior related to impulse control disorder, as mentioned by doctor. And those behavior include gambling, hypersexuality, and compulsive buying. So we decided to adjust the medication for this patient, And we do increase the levodopa and carbidopa up to third quarter 6 times a day. But we don't think that we should stop using pramipexole immediately. We need to gradually decrease the dose in pramipexole. So we reinstate pramipexole back with half of the previous dose, and we continue to use the amantadine. So through this case, I want to remind of an undiagnosed complication in Parkinson's disease, which is impulse control disorder. ICD may occur in 14 to 40 patients with Parkinson's disease. And the most common behaviors include pathological gambling, hypersexuality, compulsive shopping, compulsive eating, hobbyism, bonding, and compulsive medication use. QURPRS is useful for diagnosis, screening, and severity grading. And the widely accepted risk factor include dopamine agonist use, younger age at disease onset, male gender, and prior history of anxiety or depression, substance use, REM sleep behavior disorder, or a higher rate of dyskinesia. And the patient in this case had many of risk factors. And the first line management include gradual dose reduction and complete withdrawal of dopamine agonist if possible. And I think we need to reduce or adjust the dose slowly because the abrupt stop of dopamine agonist can lead to many complications. Yeah. And in the second case...
Okay, may I pause you for a
Okay.
minute, because I think that you show a very good case here. Can you go back to the that MDS UPDRS?
Yeah.
The one before.
MDS UPDRS, yeah.
Okay, I think this is quite important, and it tells us a lot of things. And as the doctor mentioned that he might consider DBS, right, for this patient. Would you, based on the information here, so maybe can discuss a bit, would you consider DBS in this patient? Any comments at all? The history, young onset Parkinson disease, clearly have the fluctuations. But interestingly, you get this number on the screen. Would you?
I think I would be quite worried to do it immediately because, I mean, although DBS can be used as part of the treatment nowadays to treat neuropsychiatric problems, but in a patient who has ICD score QUIP-RS 23, depression scale as well, which is 10, is it? The max depression. So I would normally reduce the dopamine agonist until the neuropsychiatric symptoms are quite well controlled first. But I guess there is indication in terms of the wearing off effect and the motor complications in this patient, where she's already on 3-hourly levodopa. And when we reduce the dopamine agonist, the motor symptoms become even worse, and that would probably affect the functioning. So, I mean to say, I would say yes, but probably not immediately.
Yes, that's a very good point. The other thing that I want to point out here, that if you look at the part 3 score, you see that on and off, the difference is not that much. It's 51 and 43. However, the patient has a dyskinesia already for 60 minutes. It tells us something, isn't it? That what does it mean by that on-time MDS UPDRS with the dyskinesia observed, and the part 4 is already score 7. So I found that there is a little bit not clear cut there. But I just want to point out here is that there is already a consensus Delphi panel on the criteria for considering device aid or device aid therapy in advanced Parkinson's disease patients. And I think that we know some of the important indicators, like for example, off time, disabling off time for at least 2 hours per day. This one thing. Disabling dyskinesia, taking medications more than 5 times a day. These are the important indicators. And for considering, deep brain stimulation, for example, but I just found that there a little bit discrepancy. So I would be very careful in considering the deep brain stimulation for this patient with this type of scoring, though. Any other comments? Okay, good case. The other thing that I thought that this case is quite strike me is that the patient decide to stop pramipexole himself. That is very brave for the patient. I have not encountered patients that decide to stop the dopamine agonist him or herself, particularly young onset patients, by searching, finding the side effects of the medication, and then, okay, I better stop it. And so that is quite quite a courage of the patient, really. Yeah.
Yeah. He's a member of a Parkinson Disease patient club, and they share information, and he know about ICD, and he stopped using it on his own. Yeah. Yeah. Thank you so much. And my second case is on a 48-year-old female who came to us because of difficulty in walking, which respond poorly to the medication. Regarding the patient history, since 2015, he reported of frequent talking and limbs movement during sleep. He also had quite severe constipation, which make her regularly visited gastroenterologist. But not until 2019, she reported the first motor sign, which is slow movement and stiffness on her left hand, then spreading to her left leg. 8 months later, she got diagnosis with Parkinson disease and received treatment. In the first 1 year, she had a partial improvement with medication. But after that, she had a poor response to medication. She started to have other abnormal movements. She also had progressive balance impairment and frequent and urgent urination. In the beginning of this year, she started to have urinary incontinence, and the gait disturbance is so severe that she have frequently fall. And her caregiver also reported of several syncope attacks, and they also noticed stridor during her sleep. Yeah, and her previous prescription before coming to us, she used levodopa, carbidopa 5 times a day, and pramipexole 3 times a day. So this is the video of the patient. On the left side is during off stage, and on the right side during on stage. Oops. I hope you can see it. During his off stage, she had a bilateral bradykinesia. She also have an ataxic gait. She need assistance her walk. And during her on stage, we can notice abnormal movement of her leg, her neck, and her right arm. During the on-stage, the bradykinesia did improve.
This is how many years of the symptoms now?
3 years after the onset of the first motor symptom. She didn't have a ataxia of her limbs.
Would she declare that she had benefits from the medication?
Yeah, she did have the benefit from the medication, but with the bradykinesia, the stiffness and slowness of her hand or her move, but the gait or the balance symptom did not improve with medication. Yeah. And other side not shown in the video. This patient had a normal consonance, normal range of eye movement, no spontaneous nystagmus. She had impaired smooth pursuits and intact saccade. She didn't have limb ataxia. She had a hyperreflexia and Parkinson's sign on her left side. She lost of postural reflex and had a ataxic gait. And to assess the patient, the MDS-UPDRS resulted Part 1 E15, Part 2 E28, Part 3 during upset E56, and Part 3 onset E32. The normal cognition with MNSE E29. And because of the history of several syncope attacks, we evaluate the blood pressure and the pulse in different positions. And she had a severe drop in her blood pressure within 3 minutes of standing to 65 per 50 without the pulse increase. So to sum up, this is a 48-year-old female with 3-year history of progressive asymmetric Parkinsonism with partial response to levodopa. She had fluctuation in levodopa dyskinesia. She had postural instability, neurogenic orthostatic hypotension, and urinary incontinence. So the question is for the audience. Do you recommend any differential diagnosis for this, or do you have any other diagnosis for the patient?
Okay. Yeah. Okay. Any comments? She asked for not only one diagnosis. You asked for the differential diagnosis, right? So that person needs to give the differential. Please speak louder, please.
Yeah, we do have a MRI. So okay, we're going to show. Okay.
She wants a differential first before the MRI.
I think that with the picture, clinical picture, is maybe
so is some
MSA.
sizes of.
It's a MSA.
But I think clinically, it is very suggestive.
Yeah,
Already very suggestive of one another.
Yeah, for everything,
Parkinson
for
the syndrome.
yeah, for everything we have in summary for this patient is the patient young onset with Parkinsonism and with a lot of symptoms, for example, fluctuation and levodopa dyskinesia, posture respond partly with levodopa, and especially the patient have a nocturnal steroid is typical signs of MSA. And I think it's MSA, because I need more detail for confirming the diagnosis on.
But clinically, Dr. Tuan, what do you think? What is your impression, your clinical impression about the diagnosis of this case? Can you have your comment before looking at the MRI? Okay.
Yes, I think it's MSA.
Okay. You agree? Okay. What MSA? What type of MSA? P or C? Pardon? MSAC. C. Okay. You can ask.
I think there is the presence of Parkinsonian, right? And you think it is a C type of MCA?
Do we agree? Do you have the unanimous here?
MCA, MCP. You have to choose between
any
the two.
other differential diagnosis? Because you asked for the differential. Okay, that's one more. Go ahead, you take the microphone to that. Yes, I like this audience. They're very enthusiastic.
I think this patient had Parkinsonism and autonomic dysfunction, so MSAP is my diagnosis.
Because
this patient have Parkinsonism and autonomic dysfunction based on urinary incontinence and neurogenic orthostatic hypotension. Okay. So I think MSAP is my diagnosis.
Okay. Maybe if we could ask the expert, Dr. Lim, you to talk about, you lecture this topic. Would you agree? Would you have any other differential?
Yeah, so it's always between whether it's Parkinson disease or atypical Parkinsonism in this case. And in this case, if the autonomic symptom seems to be quite prominent at 3 years onset, you sometimes do get a bit of asymmetry also, although, I mean, typically we learn that the atypical Parkinsonisms are symmetrical, but you can't get asymmetry. Even in PSP, sometimes you get some asymmetry as well. So yeah, MSAP, I would agree.
Can these patients still have Parkinson's disease? Look at the score. MDS-UPDRS 3 is 56, part 3 is 32.
Nearly 40% improvement.
Is it still possible to have Parkinson's disease? And what else in the differential? He asked for the differential. We have the ladies here. One of you has to speak, I think.
I have to discuss between two topics. It should be divided into two topics. One is that the patient with the suspecting of atypical Parkinsonism also have features of levodopa responsive. That's the one point. And another point is that for your question that whether this patient can have Parkinson's disease, I think yes, because all of you already asked for the differential diagnosis. Yes, one reason is that there is also levodopa responsive at least more than 30%. But this patient, if she has Parkinson's disease, it would not be the only one disease. It should be combined with another pathology, like maybe the vascular Parkinsonism, which may have gait or postural instability problems. And maybe combined with the other structural abnormalities, which we could see in the MRI brain. So for the differential diagnosis, I think it would be the MSAP, which has the features of levodopa responsive, and another differential diagnosis would be the Parkinson disease combined with another pathologies like the vascular Parkinsonism or others.
So because I quite agree with you, these patients actually improve over 40% with the medication, has levodopa-induced dyskinesia.
Yeah.
And it's relatively young. To diagnose MSA in the early 40s, we have to be careful. It doesn't, it doesn't mean that it's not possible. It can, but early 40s, like 44 with MSA is a bit unusual there. The other point, maybe I ask Dr. Srinkian to comment, is abnormal breathing sound at nighttime. Would you always put that as a stridor?
Before we go to the abnormal stridor, may I comment a little bit? And I'm not sure she has a obvious motor complication, right? Like end of dose and dyskinesia. She already have it.
Yeah, she already had.
Maybe another
Recently she has
one differential diagnosis that we keep in mind is that genetic Parkinson disease, like the Parkin mutation, which can cause in the young onset and early dyskinesia, for my opinion, apart from the MSA. That the question that Professor Pitayasiri asked about the stridor in the nighttime.
Yeah,
It
but unfortunately, that patient was not. We could not put her in the polysomnography, and that is just a symptom reported by her caregiver,
yes.
so we can't confirm it. We could.
Would that be?
Yeah.
But
we didn't notice it during her hospital stay.
But the nocturnal stridor is one of the characteristics of the MSA, but you have to clarify it is a true stridor. And actually it can fall in the daytime, like also maybe during the awake stage, and you can find the evidence of the stridor. But another differential diagnosis of the nighttime voice or noise is maybe you have to exclude like OSA or another, or vocalization of the Parkinson REM sleep behavior disorder. Is my comment.
Okay, I think good cases really. Then I mean, they just want to point out here that I didn't mean that MSA is not likely in this case. It's certainly in the differential, but we need to be careful in the early 40s. The differential diagnosis of Parkinsonism with dysautonomia actually is very wide.
Yeah.
There are many conditions with the MSA mimics, so we need to be very careful about it.
Yeah.
Yeah. I don't know how much time we have.
Excuse me, I have questions. Is that very common that MSA patient they have Babinski sign? Is that common?
Yeah. It is included in the diagnosis criteria of MSA, so I think it's a quite common symptom of MSA. Yeah, hyperreflexia and Parkinsonism.
Yes, I'm neuromuscular, so I have silly questions. I have to do all the autonomic tests in this hospital. So my question is, do we need autonomic tests to confirm MSA? MSA is just a clinical diagnosis. And what is the value of autonomic tests in very end stage of Parkinson's disease? Do you do autonomic tests for this case at your center? Thank you.
Okay, who wants to answer this? I think it's going deeper and deeper now. And it also depends which autonomic test that you are referring to. Which one?
In this center, we have a composed of 5 autonomic tests,
Wow.
including the SS, R, and it's 5 composed of 5 tests.
You do sphincter EMG in this case.
EMG, yes.
Sphincter,
no.
no.
Sphincter.
Okay, so what autonomic test were you referring to?
RR interval, SSR, orthostatic hypotension with the ratio of 38-15 ratio to confirm neurologic or non-neurologic hypotension. And isometric contracture.
I see.
Yeah.
Okay. Would anybody would like to comment?
Some notification about the Babinski sign. The Babinski sign may be rarely, but may be present in MSAP. But don't forget that there is also another sign, I forget the two side of extrapyramidal side syndrome.
Striatal.
Yeah, the striaton 2, the striaton 2. Maybe you can, maybe it is a Babinski side, but also you cannot avoid the striaton 2. Yeah?
Yeah. Professor Lee asking, are you sure that this is Babinski, or in fact it is a striatal?
Yeah, I'm quite sure that
Okay.
it's Babinski.
You're certain it is a Babinski? Okay.
You can see in the video there's no striatal.
All right. Okay. That topic is very important. Actually, it requires a long discussion. But I think that what test that we need is to differentiate between preganglionic and postganglionic disorder. Really, in this type of patient. So, like for example, if you have a cardiac MIBG, this patient would be a very good candidate for the cardiac MIBG to differentiate it.
Yeah. So, as you can. As we have discussed, this patient had many red flags, including gait impairment, severe autonomic failure. She also had a recurrent falls, and she had unexplained pyramidal tract sign, hyperreflexia. So we suspected of atypical Parkinsonism, and we have deliver a lot of investigation. This her MRI, as we can observe in this picture, there is a putaminal atrophy with the hyperintense dream sign bilaterally, and there's no atrophy of her points. So based on the recent published diagnosis criteria of MSA, this patient can have a clinically probable MSA because she have an autonomic dysfunction, an Parkinsonism, and she didn't fulfill the criteria for the cerebellar symptom because she just have a case of ataxia, and she have 3 supporting motor feature, including rapid progression and moderate to severe postural instability and an unexplained Babinski sign. And we decided that this patient had a clinical probable MSA type P. So through this case, I want to emphasize some points in diagnosis of MSA. The effectiveness of levodopa in MSA has been reported as 30 to 65% in both clinical and pathological cases. Motor complication has also all been reported in levodopa responsive MSA patient. So the occurrence of motor complication is not a reliable distinguishing feature of PD and MSA. And this is what I have been taught through 5 years Some atypical Parkinsonism may be phenotypically indistinguishable from idiopathic Parkinson disease during the first 5 years. And this is the end of my presentation. Thank you so much for your attention.
Thank you very much. Very good case, really. And I think that the other sides of the motor fluctuation in MSA that I want to mention is orofacial dystonia, which we have not seen in this case. And the presence of autonomic dysfunction in this case that you documented, that was when she was taking levodopa. We need to be careful about it to claim that this is an autonomic feature.
Actually, one differential diagnosis we will think of at the admission of this patient. We can a Parkinson disease patient have a severe hypotension, orthostatic hypotension due to the medication, high dose of dopaminergic hypotension medication like this one. Yeah, that's what we are afraid of. That the hypotension is because of the high dose of medication. Yeah.
Thank you.
Dr. Yuan, with your new diagnosis, MSAP, did you continue the use of dopamine agonist like pramipexole? Because this patient has a very worse orthostatic hypotension.
We gradually reduce the dose of dopamine agonist and withdraw dopamine agonist after this diagnosis.
Thank you. Just a small comment for me for differentiate, for make sure the differentiate from Parkinson disease and MSIP for the previous patient. I think when you talk about the EMG of the anal sphincter, I think it is very important for this patient because we know that the MSA makes the degeneration of the ONAP nucleus. So maybe we will find out some activity of the innervation of the anal sphincter, and it will make the differentiation from the two diseases. Is for me. Thank you.
It is a very useful test, though, but it's highly uncomfortable to the patient, as far as I understand. And also nowadays, it's not entirely specific. It's highly suggestive, though it's not entirely specific. Post-residual urine is easy to do, to see if it's more than 30 mL. I think that is another thing that we use. Okay, sorry.
Oh, thank you. So I have two cases to share. So the first case, I will show you a video. 60-year-old woman who presented with stiffness of the limbs and frequent falls for about 1 year. And she's currently on levodopa benzorazide 50 to 100 milligrams, 1 tablet 4 times a day. Can we have the sound?
Okay.
Yeah.
No.
You see your answer now.
Not yet, not yet.
No. Okay. One no, no. Tao nè.
Okay, so which Parkinsonism cardinal feature is shown in the video?
Okay, any answer?
A, bradykinesia, B, rigidity, C, tremor, and D, postural instability. Or we can ask how many say A, just put up your hands. B, C, tremor, and D, postural instability.
I presume that the patient has D2.
Yeah. So the first part is you see bradykinesia, and then later on comes postural instability. So that is shown. So the second question, are there features of atypical Parkinsonism? And if there are, what are they? Anyone wants to answer?
Okay, any volunteers? Yes, very good. Thank you.
Thank you. I see the cervical dystonia. I see the abnormal mobility of the movement of the eyes. Her eyes. Maybe the retroscolis, maybe.
Okay,
and,
good.
And a limitation of the vertical movement of the eyes.
Yes, abnormal vertical movements of the eyes, and also there's less blinking. And if you notice the face, there are ecchymosis bruises on the right cheek level due to a fall that you can see here, and also the chin. So she just had a fall not long ago.
Very nice.
And you can see the gait, a little white base and a little bit swaying on that side. So retrocortis, hypokinesia without decrements, early falls, wheelchair sign, limited vertical eye movements. The diagnosis?
Diagnosis. You can shout out what diagnosis. To say that this patient doesn't have PSP. Okay, answer. You agree that it's PSP?
Yeah. Okay, great. So PSP, progressive supranuclear palsy. So I guess there are more than one questions would like to ask this patient, but what would be the question you would like to ask if you see this patient in your clinic?
What question? Probably there are many questions.
Yeah, to determine whether...
Name a few. Yes, okay.
So I will push the question, Madam. Have you any difficulties for looking the objects in the at the lower position?
Okay.
What else? I think swallowing would be very important to ask about this patient too.
Smell test. Yep.
Yeah. Yes.
I think that I will ask I will make the poll test for patient, and then I will ask when the time the first symptom appear, and what the first symptom of the patient. I think that the patient have many time of fall before.
Okay, great. So I would ask whether there's a response to levodopa to determine it further. What bedside test would you do for this patient?
I think this doctor mentioned the poo test. That's one thing
Okay,
to do.
yes.
Okay. What other bedside? I think doctor, what else? What bedside? You can name many, right? The choice is not limited to one, right?
Yeah.
Okay.
So I will do a Montreal cognitive assessment. Look for any early dementia in this patient. So PSP is a neurodegenerative disease, and typically it presents above 40 years of age, and it's a tauopathy. Presentation can involve the axial akinesia, rigidity, retrocortis, postural instability, early falls, and the supranuclear gaze palsy itself, or even slowing of the saccades only. Look for pseudobulbar dysphagia and dysarthria. and lack of response to levodopa and early dementia. It generally has a poorer prognosis than Parkinson's disease. And you can see these two patients with the characteristic, the procedural sign in the top patient and the retrocolic nature in this patient and early falls. So these are some of the faces of patients with PSP that you can see here. And it's not just described. In fact, Charcot's in 1888 paper showing the faces of patients with PSP or atypical Parkinsonism. And even in the India group, you can see the procedural sign in the first one, the surprised look, the anxious look with chin dystonia, and mask-like faces. So look for all this. What next investigation would you do? You want a scan, a brain imaging, and you can see that this hummingbird sign where there's atrophy in the midbrain and the Mickey Mouse sign if you got the axial cut. So this is just the clinical criteria. I'll just go quickly. Probable PSP would be repeated unprovoked falls within the first 3 years and or tendency to fall on the pool test within the first 3 years. Progressive gait freezing, Parkinsonism, frontal cognitive behavior presentation. And you have these mandatory criteria, which is sporadic occurrence, age 40 or older at the onset of first PSP-related symptom, and gradual progression of PSP-related symptom. And you have the core clinical features, which would include the ocular motor dysfunction, postural instability, akinesia, and cognitive dysfunction. So if you have O1 or O2 and P1 or P2, you get a Richardson syndrome subtype of PSP. So you could take a look at this nice paper. We go on to the next case.
And I just want to point out that this patient probably has a clear Richardson phenotype, and the one that you mentioned there. Yeah.
So we go on to the next case in view of the time. A 48-year-old man with stiffness of the shoulders and upper limbs limiting his activity, like opening the door for 9 years. He has non-motor symptoms, poor sleep, anxiety, poor appetite, and depression. A Montreal Cognitive Assessment of 26 out of 30, which is quite good, and a Unified Parkinson Disease Rating Scale. At that time, because we had the old UPDRS scoring, so the on-off testing from 49 to 14 after levodopa. She's on Trihex, 2 mg 3 times a day, amantadine 100 mg 3 times a day, slergeline 5 mg twice a day, levodopa, benzorazide 1 tablet 200/50 mg every 3 hours. Okay, look, để với tao chỉ dùng gì quy điểm?
Cái câu
Quay. Okay. Okay. So this is on medication. And this is a home video of him showing this hyperkinetic movement.
What time of the day is this?
This is in the afternoon.
In the afternoon.
Yeah. So the question would be, this is a clear cut of a patient with Parkinson's disease. My question would be, what's happening on medication?
It's quite a nice phenomenology that you demonstrate there. Any volunteer?
Yeah.
คุกกี้อะไรไหม
In this video, I saw chorea in his extremity, upper extremity. And I think this consistent with levodopa induced dyskinesia. And from the video, I saw the contraction of his frontalis, and I don't know, maybe orthopostural dystonia. So the diagnosis of this patient may be consistent with maybe you have to think about a typical Parkinsonism. So that I think maybe multiple system atrophy or other atypical Parkinsonism.
Okay, very good. 9 years down the line, but she still had very good response to levodopa, and this is clear-cut dyskinesia. The question is, which dyskinesia do you think it is? Is it at the peak of his dose of the medication and levodopa, or is this a diphasic type of dyskinesia that we are dealing with?
I agree with Dr. Puki that this patient developed choreiform movement and note that the chorea is prominent on the upper body, both arms, and so I think this patient have the peak dose dyskinesia, which is the prominent on the upper side. If it's the diaphasics, it will be prominent on the lower limb, and the phenomenology is kind of be dystonia.
Okay, thank you very much. Yeah, so very rightly mentioned. So in the early time when the first, what we call as a honeymoon period of Parkinson, maybe the first 3 years or so, most patients, when they take their levodopa, it would last long. It would last probably maybe about 6 hours. They don't develop dyskinesias, medications. They are very happy. But maybe after 5 years, maybe about around 50% of them started having motor complications. And you can see that the medications become shorter and shorter. They may last maybe about 3 hours, 3+ hours, some even 2 hours and so. And as time goes by, you tend to also develop dyskinesias and those choric movements that you see over there. And it's estimated about 10% per year after starting levodopa, and the higher risk group would include things like younger age of onset, longer use of levodopa, higher individual doses of levodopa. And because this is more cervical, predominant, truncal and upper limb, so this is a patient with peak dose dyskinesia. The medication, it's at the levodopa is at its peak. And this is quite a nice diagram from Annals of Neurology showing how we could differentiate based on the phenotype, peak dose dyskinesia versus diphasic dyskinesia, and off dystonias normally at the in the foot, and advanced Parkinson's disease. You may have a bit of mixture of the dystonias of the foot plus the dyskinesias at the orofacial region plus the limbs. And then in MSA, you get the pattern that you see in F here. So this is another home video of his showing a peak dose dyskinesia. You can see the neck is moving on its own, the upper limbs. The first video that you saw, you don't see much of the upper limb because he was holding on the chair very hard. So you don't see a lot of movements, but if he were to let go of the movements on the chair, the upper limbs would be more dominant. So this is the pattern that he's having. So how would you manage wearing off, the first question? So you could, number one, do add-on things like monoamine oxidase inhibitors such as selegiline, COMT inhibitors, or dopamine agonists. Or you could increase the dosage of the levodopa or shorten the intervals between the levodopa dose, but I guess he's already taking 2-3 hours. Third one, you may want to advise to take the medications before meals, and then there are some studies of eradication of the H. pylori, which would help the absorption of the levodopa. And then lastly, advanced therapies such as DBS, apomorphine, and levodopa, carbidopa infusional gel. How would you manage peak dose dyskinesia? Perhaps decrease the levodopa dose, but a lot of times when you decrease the levodopa dose, then they become off. Without dyskinesia, but they become off. Second, you could discontinue the agents that potentiate the levodopa, for example, the MAOID inhibitors and COMT inhibitors. You could add in a dopamine agonist, but instead you may need to reduce the levodopa. You should add in amantadine or then advanced therapies. So peak dose dyskinesia is at this position here. Now we go to another video of the same patient. And what is this motor complication? So he complains mainly only at the legs this time, hardly at the hands. And you can see the toes. And this is when the level is much lower without medication. So I would say this is a diphasic dyskinesia, but just keep in mind that diphasic dyskinesia, as you can see in the last diagram here, it can occur just from off, they go into diphasic dyskinesia because of low dose of the levodopa and continue to have diphasic dyskinesia and become off, or they can have an on period and then diphasic dyskinesia and then on and then become off. So there are three ways that can happen here. So in the end, we did bilateral STN DBS for him, which was, I would say, successful. The right side is during programming. Yes. The effect on DBS on the tremor is normally very dramatic, and patients feel very happy with the outcome of that. Okay, so that's my last case.
Thank you very much. Very good cases.
Because we don't have apomorphine infusion in our country, so I would like to ask advantages and disadvantages of apomorphine infusion over the DBS.
Maybe Ronald, your answer. You use more apomorphine.
Yeah. I would agree that this patient would be better with the deep brain stimulation, really, because the predominant feature is the dyskinesia, different type of dyskinesia. Apomorphine, efficacy on dyskinesia is not very, robust as the deep brain stimulation. Part of it might be related to the dose reduction of the apomorphine, might not be that as much as the deep brain stimulation. So, putting all that together, I think that with the predominant dyskinesia, I would prefer this patient for the deep brain stimulation.
He's also, I think at that time, 48, so he was relatively young, and he wanted to be more independent compared to holding a palm all the way. And cognition was still very good in him.
And with the dyskinesia, which looks quite malignant, to have that with the system, with the pump system, would be a bit difficult. And the pump and the needles probably would have a little bit of the technical issues there. Yeah.
Thank you.
Thank you.
Okay. Thank you very much, Dr. Lin Tian and Dr. Ian. It's time that you have some relaxed